everyone. Thank you so much for having me. I'm Susan McClory. I am coming from the Children's Hospital of Philadelphia. So we are so excited to be here at this conference and representing CHOP to you guys. And I'm going to talk a little bit today about oncologic emergencies. And really explicitly want to focus this on a pediatric population and for general pediatricians and what you may carry into your practice in any specialty. And so I'm going to focus on a few areas. I just want to warn you, this is a very general overview. Each of these could be a topic for an entire lecture on their own. So please feel free to ask questions during the question and answer section. So I'm going to start first with a broad category of oncologic emergencies, and that's infection. Infection is one of the largest causes of morbidity and mortality for our patients, and it's something that we worry very much about, both in a new diagnosed patient or in patients who have been undergoing treatment and are very immunocompromised. So we have special considerations for our patients who have cancer or are suspected to have cancer. Specifically, patients may not show signs of infection the way that patients traditionally do when they're not immunocompromised. We have a very low threshold for considering infection, and it's one of the things that is always at the top of our mind. And this is especially true for patients who are very immunocompromised. So our patients who have undergone stem cell transplant, patients who have received cell therapy, patients with certain hematologic malignancies, and then also patients with immunodeficiencies such as SCID patients or other primary immune deficiency. So why are our patients a little bit different than other pediatric patients? And so we know that cancer can increase infection risk by, number one, bone marrow suppression. This may be true at a new diagnosis for a patient who has a hematologic malignancy such as leukemia or bone marrow involvement by other cancers as well. Or it may be due to the treatment that we are giving. Most of the treatments we give suppress the bone marrows to a certain degree, and this can be very problematic. Mass effect of a tumor can also cause infection by causing obstruction and then subsequent risk for infection. The therapies that we give, so chemotherapy, radiation, conditioning regimens for transplant, all of those can disrupt the normal barriers to infection. And so things that patients typically have to help prevent infection from getting in are sometimes broken down in our patients with oncologic diagnoses. Causes then poor wound healing, which is a risk factor for infection. It can disrupt the mucosal barrier, and we also place foreign bodies, such as a central line, to give our medications, which can cause infection. Some high-risk features for infection include prolonged neutropenia, lower absolute neutrophil count, or a low lymphocyte count. So what do we think about when we're managing infections in a patient with either a new diagnosis of cancer or a patient who's been undergoing therapy? We think about early treatment, so antibiotics within the first 60 minutes of fever for a patient with neutropenia or central line. And we hope that these antibiotics are very broadly covered. So antibiotics that cover both gram-positive and gram-negative bacteria. And then in certain populations, we also consider antifungal or antiviral therapy. That is true especially for patients at high risk of infection due to their profound immunocompromised status. We also think about when we're treating a patient or with an oncology diagnosis who may be septic, that capillary leak is a significant problem for our patients. So we're very careful with fluid resuscitation. Fluid resuscitation with antibiotics are the first mainstay for treatment of sepsis in our patients, but because patients may have capillary leak due to epithelial damage, we also are very careful about early use of vasopressors as well. Moving on next to the broad category of hematologic oncologic emergencies and things that you should consider in patients who have a new diagnosis or established cancer diagnosis. So with this, I'm going to present with a case of a child. This is a 3-year-old boy who presents with pallor, fever, lethargy. You note on exam, he has this rash that is characteristic here and then also that he has significant organomegaly. His liver is very large, and the spleen is very large. On labs, his white count is noted to be 983,000. His hemoglobin is 5.1 grams per deciliter, and his platelets are 15,000. And so this is a child that's presenting with a classic oncologic emergency called hyperleukocytosis. This is defined as a white blood cell count with 100,000 cells or more in their white blood cells. It affects approximately 10% of patients with leukemia, a little bit more in acute myeloid leukemia than in acute lymphoblastic leukemia. And what happens with hyperleukocytosis is that it causes leukostasis, which then increases the risk for hemorrhagic infarct. And for AML, we think about hyperleukocytosis in any patient that's greater than 300,000. For ALL, 400,000 to 500,000. And then for CML, we think about it in patients that have white counts over 750,000. What is the pathophysiology of hyperleukocytosis? So it can cause increased blood viscosity because the blast aggregates. They are large, they are sticky, and they are poorly deformable, which means that they create aggregates in the bloodstream that then can increase risk of infarct. What are signs and symptoms of hyperleukocytosis? So it can cause dyspnea, blurred vision, agitation, confusion, stupor, hypoxia, plethora, cyanosis, papilledema, or ataxia. When we find hyperleukocytosis on exam or on clinical findings and labs, what we start with is hydration. So hydration helps dilute out the very high white blood cell count, and then can actually decrease it pretty drastically and prevent some of those aggregates. Many of these patients have a coagulopathy associated with this, and so we correct this by supporting them with platelet transfusions and by supporting with plasma and cryoprecipitate as needed. We are very careful with red blood cell transfusions because in this phase of hyperleukocytosis, you can increase your risk for increased viscosity. We consider leukapheresis when the white blood cell count is very high or in unstable patients. And then we also consider a very early initiation of chemotherapy, which can help decrease the white blood cell count quickly. The next hematologic oncologic emergency we think about can happen at any stage of cancer diagnosis and treatment, and this is hemorrhage. So we know that children with cancer are at increased risk for bleeding for many reasons. They can be thrombocytopenic or have a low platelet count. They can have a bad coagulopathy, increasing their risk for bleeding. They can have mucosal injury, which also increases risk for bleeding. They have multiple risk factors for bleeding due to tumors in different locations, such as CNS, the pulmonary system, or GI system. And the treatment for this is really blood product support and then treating the underlying cause. I next want to move into oncologic emergencies that are metabolic in nature. And the number one that I think most people think of when they think of a metabolic oncologic emergency is tumor lysis syndrome. Tumor lysis syndrome is when blasts or tumor cells break open and cause a rapid release of intercellular metabolites. The primary abnormalities that we see are hyperuricemia, or a high uric acid, hyperphosphatemia, or hyperkalemia. Due to these, and specifically due to the hyperphosphatemia, you can also get a secondary hypocalcemia. And all of these can cause significant renal toxicity and make the patient very ill. Risk factors for tumor lysis syndrome. So the number one risk factor is a very high tumor burden and then high chemosensitivity. And so Burkitt's lymphoma is one of the classic examples of a cancer that causes high risk for tumor lysis syndrome, because you both have a high level of rapidly growing tumor due to the lymphoma, but it's also very chemosensitive, which can then lead to tumor lysis syndrome. A very high LDH is also a significant risk factor, and then a high white blood cell count. So our patients with hyperleukocytosis often also have the accompanying tumor lysis syndrome as well. If you start off with impaired renal function, this can be a bad sign for bad tumor lysis syndrome. or if you start off with an elevated uric acid even before we start treatment, that is also a risk factor. We manage tumor lysis syndrome by first staying on top of the labs and monitoring them very closely. Depending on how abnormal they are and how ill the patient is, we check labs every 2 to 12 hours in our newly diagnosed patients. Hydration, we typically now are starting with D5 half normal saline without potassium. And we adjust the fluid rate so that we're giving them hyperhydration. So we're giving anywhere from 1.5 to 2 times maintenance needs at the beginning. And we adjust that based on both their white blood cell count, their tumor lysis labs that we're checking frequently, and then also their volume status on exam, because we frequently need to make adjustments in that to keep them safe. And then simultaneously, we're considering diuresis, especially in patients who require a lot of IV fluids to keep their tumor lysis labs in a safe range. We consider using furosemide as needed for diuresis to help get off some of the fluid that we are also giving them. For the actual electrolyte abnormalities, each of the abnormalities sort of has its own management. So for high uric acid, we use allopurinol in most of our patients. When the uric acid is incredibly high, greater than 8 or 9, we consider using urate oxidase or rasburicase. We cannot use this in patients with G6PD deficiency, so we always check the status of that first. Hyperkalemia, we treat just as hyperkalemia in any other pediatric patient that were to have a high potassium. We treat with Lasix, with calcium, with sodium bicarbonate, glucose, insulin, or GI binder like Kayexalate. Rarely, we need to use dialysis as well. The next metabolic crisis that I want to talk about in oncologic emergencies is adrenal crisis. And this is just something that we have a low threshold for considering in most of our patients. Most of our patients that have leukemia, or many patients who have had transplants, have had a lot of exposure to glucocorticoids during their treatment. Because of this, they may be adrenally insufficient and may need replacement glucocorticoids when ill. Signs can be subtle in our patients, and so you may have a patient who has a fever who's a little bit more sick than you would expect just with a fever. It can present as fatigue, dizziness, weakness, poor appetite, body aches, joint pains, or persistent nausea and vomiting. You can also have severe life-threatening adrenal insufficiencies, such as hypotension or shock. We consider early steroids in our patients who are unstable with a lot of these signs. I just put at the bottom just a word of caution. There's some of our patients that we think a little bit more carefully about using steroids right at the bat, and that would be patients who have received a cell therapy, which is something we're increasingly doing at CHOP. For those patients, we wait a little bit to give steroids if the patient is safe to do so. I next want to talk a little bit about mass effect. So this is a common presentation for large, bulky tumors, is to have some significant clinical sequelae of a large mass or tumor. So the first oncologic emergency that we typically think of in the mass effect category would be superior vena cava syndrome or superior mediastinal syndrome. We use these two terms pretty interchangeably, and they're really defined very similarly. So SVC syndrome is compression, obstruction, and thrombosis of the SVC. Superior mediastinal syndrome, on the other hand, is SVC plus tracheal compression. And we use these interchangeably. This is just a picture of what this can look like and really demonstrates why these are such clinical emergencies. This is a patient presenting with a large mediastinal mass here that really takes up most of its thoraco diameter. And then over here, you can actually see significant compression of the trachea due to a mediastinal mass. And this can be a clinical emergency that can be diagnosed, in any place in pediatrics as a presenting sign of a mediastinal mass. And so the signs and symptoms of this are first respiratory distress. Sometimes this presents dramatically, but this could also be a respiratory distress that has developed slowly over time. Potentially a patient tells you they now need to sleep on 2 pillows because they feel uncomfortable when they lie flat. They may have more wheezing in a patient who already had wheezing before because of the compression. Sometimes family members will notice swelling or engorgement or fullness of the face, neck, or upper extremities due to that superior vena obstruction. They may have tracheal deviation on exam. And signs of a clinical emergency that we really worry about, any patient who tells you they feel anxious and has these clinical signs, or who feels an impending sense of doom, we are very worried about. Confusion, lethargy, headache, visual disturbance, or syncope or passing out due to these symptoms are also signs of impending emergency. And so, what do we think about in a patient who presents to our oncology service with superior mediastinal syndrome? Number one, we've got to figure out how to treat this to relieve the obstruction. Number two, we have to find out what is actually causing it. What is that mass? What's the diagnosis? And that's why I bring up here, because there are a lot of significant considerations we have when we have a new mediastinal mass causing SVC syndrome, because the risk of anesthesia is significant in these patients. The way we diagnose these tumors is generally by a biopsy, and often that comes with other procedures such as bone marrow biopsies. And so in order to do those safely, we have to think about the other risks associated. And with anesthesia, we know that there's an aggravated compression of the vena cava. It relaxes the respiratory muscles tone. With anesthesia, we get increased abdominal tone. We get decreased diaphragmatic movement and decreased lung volumes. We also may have mass compression of the trachea, causing difficulty with ventilation from above. And then anesthesia also causes decreased respiratory drive and dilation of peripheral vessels, which causes a decrease in venous return. And so anesthesia can actually be very unsafe in these patients. And so we think very carefully about how we perform our procedures. If a patient is unstable, and we have worked very closely with our anesthesia partners, we think about doing patients as alert as possible with decreased sedation and really utilizing any type of local anesthetic that we can. We also think about doing biopsies such as bone marrow biopsies, either delaying them until the patient is more safe, or doing anterior bone marrow biopsies rather than ones on the back to keep the patient safer during anesthesia. And then finally, there are times where we can't do any type of anesthesia, and we could not safely or with proper anesthesia do these procedures. And so we sometimes just have to treat and delay the procedures until later. The next type of mass effect I want to talk about is spinal cord compression. So this is something that can present with a number of different either neurologic tumors or solid tumors of other origins. And here you're just seeing a picture of what this can look like, where the spinal cord has been very compressed by a mass. The way we diagnose this is usually by physical exam. A really detailed neurologic exam is critical in patients who have suspected spinal cord compression or even tumors anywhere in the region of the spinal cord at all. If that neurologic exam is abnormal, we start steroids, dexamethasone, for presumed vasogenic edema. And then we also get an urgent or emergent spine MRI as soon as possible to find out what we're dealing with so that we can then address it. Emergent therapy to help decrease it outside of steroids alone is really dependent on the type of tumor that we're worried about. Surgery is often considered, especially if the diagnosis is unknown, and especially if surgery is deemed to be safe enough or diagnostic based on the location of the tumor. Radiation is another consideration depending on the type of tumor you're most worried about. And then chemotherapy for any type of chemotherapy-sensitive tumors. And this is especially true if we're worried about leukemia or lymphoma. And then next, for abdominal masses, these too can cause oncologic emergencies, although maybe a little bit less rare. But because oncologic masses can become very large, you have to worry about rupture, hemorrhage, obstruction, or renal failure. And the way we treat this usually is by removal, but not always. Sometimes it's by urgent or upfront chemotherapy or radiation. The next category of oncologic emergencies, and sort of where I want to end, is other treatment-related toxicities. So there's a lot that we give patients in the course of their cancer diagnosis that can cause significant side effects And sometimes these are emergent and critical to act on very quickly. So typhlitis is one category of this. Typhlitis is also known as neutropenic enterocolitis. And the pathophysiology of this is that we give cytotoxic chemotherapy to kill the cancer. This then causes mucosal injury and neutropenia simultaneously. Both of those things impair the host defense, and then this can lead to polymicrobial bowel translocation and invasion. And with this, you then get transmural bowel wall inflammation and necrosis. And patients can present with anything ranging from significant abdominal pain all the way to an acute abdomen. Radiographic findings can include pneumatosis or even air within the abdominal cavity, and can be quite impressive. The way we treat typhlitis is typically with antibiotic therapy directed at both gram-negative and anaerobic organisms. And you would use your own local antibiogram or organism pathology to drive which antibiotics you specifically chose, but you want to make sure that you're using gram-negative and anaerobic organisms. Bowel rest and pain management are a primary part of the treatment, and then rarely surgery is needed for either an acute abdomen or intestinal perforation. We think about surgery very, very carefully in these patients because they're usually very neutropenic, and surgery itself is a huge risk factor. Then many of our therapies can cause significant toxicity to other organs that can sometimes then present as an urgent or emergent clinical scenario. So our patients can present with overt heart failure due to cardiomyopathy, due to anthracyclines or radiation. They can have hypertensive emergency due to a number of different types of chemotherapies we give or other treatments. They could have pulmonary hypertension due to conditioning regimens from stem cell transplant or infection. They could develop pneumothorax due to a number of different ways that we treat cancer, or pneumomediastinum. And then some cancers and some treatment regimens predispose you to diffuse alveolar hemorrhage that can be life-threatening or life-ending. Neurologic emergencies are also a significant part of oncologic care. They actually occur in 10% of our pediatric oncology patients during their therapy. They may present as acute alterations in mental status, seizures, stroke, or increased intracranial pressure. It may be due to the direct tumor effect, infection, or treatment. And the treatment-related neural complications really depend on the type of treatment that patient has received. And there's a whole list of many of the medications we give that have their own unique neurologic complications, and many of these can be emergent. And I list a few here, such as radiation, cytarabine, methotrexate, nalarabine, ifosfamide, and then I'm also including immunotherapy and cell therapy as well. And with that, I just want to end with a comment about cell therapy and transplant. So at Children's Hospital of Philadelphia, we have a large transplant center for bone marrow transplant patients. We also have a large program for CAR T-cell therapy and other immunotherapies. And what this has really taught us is that in the last 10 years, we have a new category of oncologic emergencies that are just due to these therapies alone. And so the two that I'm highlighting here are cytokine release syndrome and immune effector cell associated neurotoxicity, or ICANS. Both of these follow CAR T-cell therapy. At CHOP, most of the CAR T-cell therapy that we give is for leukemia, specifically CD19 positive B-ALL. However, we also do CAR T-cell therapy for myeloid malignancies and some solid tumors as well, and we're starting to understand these complications in the setting of those CAR T-cell therapies as well. CRS, or cytokine release syndrome, is a severe cytokine storm due to T-cell proliferation and activation. This severity is related to disease burden, although we have patients who have low disease burden who get very bad CRS, and we've also had patients who have very high disease burden who don't get CRS. So although the correlation is there and is very important to predict severe CRS, it's not perfect. CRS can cause high fevers in its mildest form, but as it becomes more severe, it can cause refractory hypotension, severe capillary leak. So these are patients that we typically only give a little bit of IV fluids before we're starting a vasopressor. It can cause pulmonary edema and ultimately respiratory failure. Treatment is evolving. So the most common treatment that we use for CRS up front is what's called IL-6 blockade, using medications such as tocilizumab or siltuximab. And then we often add on steroids as well. And then more emerging and what we're using more common or more frequently now than we did previously is interferon gamma blockade as well. ICANS is very closely related to CRS. It typically occurs a little bit later than CRS, but it's also related to disease burden and T-cell proliferation. And you can have a spectrum of neurologic sequelae. It can range anywhere from altered mental status to a little bit of aphasia to complete stroke-like symptoms or immobility or impairment. Treatment for this is also evolving and a little bit less understood than cytokine release syndrome, but includes steroids as well. With that, I'm going to wrap up. I'm coming to the end of my time. I just want to thank everyone here again for hosting us and for having us. I am happy to take questions during the question and answer section, or you are free to either email me. I give my email address at the bottom, or reach out to me after the talk, and I would be happy to discuss further. Thank you all so much.